Hello, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Chapter 64, Other Gastrointestinal Drugs. So, in this chapter, we will discuss an assortment of gastrointestinal drugs with indications ranging from emesis to colitis to hemorrhoids. Four groups are emphasized: your antiemetics, antidiarrheals, drugs for irritable bowel syndrome, and lastly, drugs for inflammatory bowel disease. So we'll jump right into antiemetics. Antiemetics are given to suppress nausea and vomiting. We begin our discussion by reviewing the emetic response. Next, we discuss the major antiemetic classes. We finish by considering the most important application of these drugs, the management of chemotherapy-induced nausea and vomiting. So let's start right off with the emetic response. Emesis is a complex reflex brought about by activating the vomiting center, a nucleus of neurons located in the medulla oblongata. Some stimuli activate the vomiting center directly, others act indirectly. Direct acting stimuli include signals from the cerebral cortex, the anticipation of fear, signals from the sensory organs such as upsetting sights, noxious odors, or pain, and signals from the vestibular apparatus of the inner ear. Indirect acting stimuli first activate the chemoreceptor trigger zone, which in turn activates the vomiting center. Activation of the chemoreceptor trigger zone, or CTZ, occurs in one of two ways. One, by signals from the stomach and the small intestine traveling along the vagal afferents, and two, by the direct action of the emetogenic compounds, so anti-cancer drugs, opioids, or ipecac, that are carried to the CTZ in the blood. When activated, the vomiting center signals to stomach, diaphragm, and abdominal muscles. The resulting coordination response expels gastric content. So here is a picture of that very action. So if you're unfamiliar with the pathophysiology, it's an excellent spot to hit pause. Several types of receptors are involved in the emetic response. Important among these are the receptors for serotonin, glucocorticoids, substance P, neurokinin 1, dopamine, acetylcholine, and histamine. Many antiemetics, including sofran, dexamethasone, aprepitant, prochlorperazine, and dimenhydrinate, act by blocking or activating one or more of these receptors. So, antiemetic drugs. Several types of antiemetics are available. Their classes, trade names, and doses are shown on the following table. Uses and mechanisms of action will be on the following table. Properties of the principal classes are discussed next. So there are prototype drugs for the gastrointestinal drugs, your serotonin agonist, your glucocorticoids, your substance P, neurokinin 1 antagonist, dopamine antagonist, cannabinoid, benzodiazepines, drug for constipation, predominant IBS, drugs for diarrhea, predominant IBS, your 5-aminosalicylates, your glucocorticoids, and your immunomodulators or immunosuppressants. So again, it's a good spot to hit pause and take a look at all of them. We'll discuss each of them throughout this chapter. So here are the two tables coming up: the antiemetic drug class, trade names, and doses. An excellent spot again to hit pause if you're unfamiliar with certain medications. We'll discuss most of these throughout this chapter. And I'll try to space it so that there's appropriate spots to hit pause. And lastly, here are the antiemetic drugs and the uses and mechanisms of action. Again, a good spot to hit pause if you're unfamiliar. So I'll jump right into the serotonin receptor antagonists. Serotonin receptor antagonists are the most effective drug available for suppressing nausea and vomiting caused by cisplatin and other highly emetogenic anti-cancer drugs. These drugs are also highly effective against nausea and vomiting associated with radiation therapy, anesthesia, viral gastritis, and pregnancy. 4 serotonin antagonists are available for treating emesis. The big ones are ondansetron or Sofran, granisetron, dolasetron, and palanositron. We'll jump into the first, ondansetron. Ondansetron or Sofran was the first serotonin receptor antagonist approved for CINV. The drug is also used to prevent nausea and vomiting associated with radiotherapy and anesthesia. In addition, the drug is used off-label to treat nausea and vomiting for other causes, including childhood viral gastritis and morning sickness in pregnancy. In all cases, benefits derive from blocking type 3 serotonin receptors, the 5-HT3 receptors, located in the CTZ and on afferent vagal neurons in the upper GI tract. The drug is very effective by itself and even more effective when combined with dexamethasone. Administration may be oral or parenteral. The most common side effect would include headache, diarrhea, and dizziness. Of much greater concern, ondansetron prolongs the QT interval and hence poses a risk for torsades de pointe, a potentially life-threatening dysrhythmia. Accordingly, the drug should not be given to patients who already have a long QT syndrome and should be used with caution in patients with any kind of electrolyte abnormalities, heart failure, or bradydysrhythmias, and in those taking other QT drugs. Because Sofran does not block dopamine receptors, it does not cause the extrapyramidal effects, so akathisias or acute dystonias, seen with antiemetic phenothiazines. The administration by the oral or PO route, intramuscular, or IV. For oral dosing, Sofran is available in a solution, standard tablets, or orally disintegrating tablets, and a soluble film. To prevent CINV, the recommended IV dose is 0.15 milligrams per kilogram, infused slowly over 15 minutes. Beginning 30 minutes before chemotherapy, this dose is repeated 4 and 8 hours later. The dosage for patients undergoing radiation therapy is 8 milligrams PO, 3 times a day. The dosage for post-operative nausea and vomiting is 16 milligrams, 1 hour before induction of anesthesia. That brings us to the second medication, granisetron. Granisetron, or granisol, suppresses emesis by blocking the 5-HT3 receptors on the afferent vagal neurons and in the CTZ. The drug is approved for the prevention of nausea and vomiting associated with cancer chemotherapy, radiation therapy, and surgery. Principal adverse effects are headache, weakness, tiredness, and either diarrhea or constipation. Administration is PO, IV, or transdermal. The recommended dosage for CINV is either 1, 10 micrograms per kilogram IV infused over 5 minutes, starting 30 minutes before chemotherapy, or 2, a single transdermal patch applied 24 to 48 hours before chemotherapy and removed 24 hours after chemotherapy is completed, but no more than 7 days after application. The dosage for patients undergoing radiation therapy is 2 milligrams once daily, given within 1 hour of radiation treatment. The dosage for preventing post-op nausea and vomiting is 1 milligram IV, injected slowly over 30 seconds, either before the induction of anesthesia or just before reversing anesthesia. That brings us to the third, dolasetron, also known as Anzamet, which is approved for CINV and post-operative nausea and vomiting. Administration again is PO or IV. Side effects are like those of the other serotonin antagonists, with one important exception. When given IV injection in high doses, dolasetron poses a significant risk for fatal dysrhythmias. Accordingly, high-dose IV therapy should not be used. Oral therapy and low-dose IV therapy is considered safe. The recommended dosage for CINV in adults is 100 mg PO 1 hour before chemotherapy. The dosage to prevent postoperative nausea and vomiting is also 100 mg PO 2 hours before anesthesia or 12.5 mg IV 15 minutes before anesthesia is stopped. That leads us to the fourth and last, palanositron. Palanositron, or Aloxi, indicated for CINV and postoperative nausea and vomiting, has the same mechanism, efficacy, and side effects as the other serotonin antagonists. However, it differs from the others in two clinical significant ways. The first being palanositron has a much longer half-life. It's 40 hours versus just the 8. Second, because of its long half-life, palanositron is effective against delayed emesis, as well as acute emesis, whereas the others are most effective against acute emesis. Palanositron also has much greater affinity for the 5-HT3 receptors than the other serotonin antagonists, but this difference does not appear to have a clinical significance. Palanositron is available only in the IV formula. The recommended dosage for CINV in adults is 250 micrograms IV delivered over 30 seconds, starting 30 minutes before chemotherapy. To prevent postoperative nausea and vomiting, the dosage is 75 micrograms IV delivered over 10 seconds, immediately before the induction of anesthesia. Which takes us now to the section of antiemetics, your glucocorticoids. There's two glucocorticoids, methylprednisolone, Solu-Medrol, and dexamethasone, are commonly used to suppress CINV, even though they are not approved by the FDA for this application. Glucocorticoids are effective alone and in the combination with other antiemetics. The mechanism by which the glucocorticoids suppress emesis is unknown. Both dexamethasone and methylprednisolone are administered by IV route. Because antiemetics use is intermittent and short-term, serious side effects are absent. The pharmacologic use of glucocorticoids is discussed in Chapter 56. Substance P neurokinin 1 antagonists. There are 4 substance P neurokinin antagonists are currently available: aprepitant, rolapitant, nitipitant, and fosaprepitant. A prodrug that undergoes conversion to aprepitant in the body. The principal application is the prevention of CINV. So we'll start off with that first one, aprepitant, its action and use. Aprepitant, or Emend, is an important antiemetic. The drug is approved for preventing postoperative nausea and vomiting and CINV. Owing to its unique mechanism of action, the blockade of the neurokinin 1 type receptors in the CTZ, aprepitant can enhance responses when combined with other antiemetic drugs. Aprepitant has a prolonged duration of action and hence can prevent delayed CINV as well as acute CINV. Aprepitant can be used alone for managing postoperative nausea and vomiting. However, because the drug is only moderately effective, it must be combined with other antiemetic drugs, specifically a glucocorticoid, dexamethasone, and a serotonin antagonist, Sofran, for managing CINV. Its pharmacokinetics. Oral aprepitant is well absorbed both in the presence and absence of food. Your plasma levels peak 4 hours after dosing. The drug undergoes extensive hepatic metabolism, primarily by the CYP3A4, the 3A4 isoenzyme of cytochrome P450, followed by the excretion in the urine and feces. The plasma half-life is 9 to 13 hours. Adverse effects. Aprepitant is generally well tolerated. Compared with patients receiving Sofran and dexamethasone, those receiving aprepitant plus Sofran and dexamethasone experience more fatigue and asthenia. about 17.8% versus the 11.8. Hiccups, 10.8% versus the 5.6, and dizziness, 6.6 versus the 4.4. And diarrhea, 10.3 versus the 7.5%. Aprepitant may also cause mild transient elevation of circulating aminotransferases, indicating possible liver injury. So, it's drug interaction. The potential for drug interaction is complex because aprepitant is a substrate for inhibitors of and inducers of CYP3A4, a major drug metabolizing enzyme. Inhibitors of the CYP3A4 can raise levels of aprepitant. Conversely, inducers of CYP3A4 can decrease levels of aprepitant. By inhibiting the CYP3A4, aprepitant can raise levels of CYP3A4 substrates, including many drugs used for cancer and chemotherapy. Among these are docetaxel, paclitaxel, etoposide, irinotecan, ifosfamide, imatinib, vinorelbine, vinblastine, and vincristine. Also, aprepitant can raise levels of glucocorticoids used to prevent CINV. Accordingly, doses of these drugs should always be considered to be reduced. In addition to affecting the CYP3A4, aprepitant can induce CYP2D6, another drug metabolizing enzyme. As a result, aprepitant can decrease levels of CYP2D6 substrates, including warfarin and ethinyl estradiol. Patients receiving warfarin should be monitored closely. Patients using oral contraceptives may need an alternative form of birth control. So, its preparation, dosage, and administration. Aprepitant is available in a 40, 80, and 125 milligram capsule. Dosing may be done with or without food. For CINV, dosing is done once a day for 3 days. The first dose, being 125 milligrams, is given 1 hour before chemotherapy. The second and third dose are 80 milligrams each and are given early on the following 2 days. As noted, aprepitant should be used in combination with dexamethasone and Sofran. For postoperative nausea and vomiting, treatment consists of a single 40 milligram dose given within 3 hours of anesthesia induction. Which brings us now to the second drug, fosaprepitant. Fosaprepitant is an intravenous prodrug that undergoes rapid conversion to aprepitant in the body. Accordingly, the pharmacology of fosaprepitant is nearly identical to that of aprepitant. Fosaprepitant is indicated only for the prevention of CINV. In contrast, aprepitant is approved for CINV and postoperative nausea and vomiting. For the prevention of CINV, fosaprepitant is used as a substitute for aprepitant, but only for the first dose in the 3-dose regimen. Because IV fosaprepitant has greater bioavailability than the PO aprepitant, the dosage for the fosaprepitant is only 115 milligrams, compared with the 125 for aprepitant. In addition, to cause the same adverse effects as aprepitant, fosaprepitant can cause pain and induration at the infusion site. Which takes us now to the third medication, rolapitant. Its action and use. Rolapitant is approved for the prevention of delayed nausea and vomiting associated with chemotherapy. Like aprepitant, rolapitant works well when combined with other antiemetic agents, including dexamethasone and a 5-HT3 receptor antagonist. Its pharmacokinetics. Oral rolapitant is well absorbed in both the presence and absence of food. The plasma levels peak 4 hours after dosing. The drug undergoes extensive hepatic metabolism, primarily in the CYP3A4, followed by the excretion in the urine and feces. The plasma half-life is very long, almost 7 days. Adverse effects. Rolapitin is generally well tolerated. However, common adverse reactions include a decrease in appetite, neutropenia, dizziness, and dyspepsia. Compared with the combination of dexamethasone and a 5-HT receptor antagonist alone, there are no significant differences in side effects. Its drug interactions, however, like aprepitant, concomitant use with inhibitors of CYP3A4 can raise levels of rolapitant. Conversely, inducers of CYP3A4 can decrease levels of rolapitant. So its preparation, dosage, and administration. Rolapitant is available in 90 milligram tablets. The recommended dose is 180 milligrams, administered 1 to 2 hours before the start of chemotherapy. Dosing should be in conjunction with the prescribed dexamethasone and a 5-HT receptor antagonist. Which brings us now to netopitant palanositron, also known as Akynzeo, which is a combo drug that contains both substance P antagonist and a 5-HT receptor antagonist. The drug is approved for preventing acute and delayed nausea and vomiting associated with chemotherapy. Pharmacokinetics, adverse effects, and drug interactions are similar to the other agents that block substance P and 5-HT3 receptors. The combo drug is available in a 300-0.5 milligram capsule. Dosing can be with or without food, and patients should take one capsule about 1 hour prior to receiving chemo. Which takes us now to benzodiazepines, your lorazepam or Ativan, which is used in a combination regimens to suppress CINV. These drugs have three principal benefits: sedation, suppression of anticipatory emesis, and the protection of anterograde amnesia. In addition, lorazepam may help control extrapyramidal reactions caused by phenothiazine antiemetics. The basic pharmacology of lorazepam and other benzodiazepines will be discussed in Chapter 26. Dopamine antagonists. Phenothiazines. The phenothiazines suppress emesis by blocking dopamine 2 receptors in the CTZ. These drugs can reduce emesis associated with surgery, cancer chemotherapy, and toxins. Side effects include extrapyramidal reactions and anticholinergic effects, hypotension, and sedation. The basic pharmacology of phenothiazines is discussed in Chapter 24. 1-phenothiazine, promethazine, also known as Phenergan, requires comment. Promethazine is the most widely used antiemetic in young children, despite its adverse effects, respiratory depression and local tissue injury, and despite the availability of potentially safer alternatives, such as Sofran. So it does have a black box warning of promethazine. Respiratory depression from promethazine can be severe. Deaths have occurred. Because of this risk, promethazine is contraindicated in children younger than 2 years and should be used with caution in children older than 2 years. Tissue injury can result in several ways. An example is extravasation of IV promethazine can cause abscess formation, tissue necrosis, and gangrene that requires amputation. Severe injury can also occur with inadvertent perivascular and intra-arterial administration, or with administration into or near a nerve. Risk for local injury is lower with IM dosing than with IV dosing. Accordingly, when parenteral administration is needed, the IM route is preferred. Subcutaneous promethazine is contraindicated. If IV administration must be done, promethazine should be given through a large bore, free-flowing line in concentration of 25 milligrams per ml, or less at a rate of 25 milligrams per minute or less. Patients should be advised to report local burning or pain immediately. Which brings us to butyrophenones. There are two types: haloperidol, Haldol, and droperidol, inapsin. Both are used as antiemetics. Like phenothiazines, the butyrophenones suppress emesis by blocking dopamine 2 receptors in the CTZ. Butyrophenones are effective against postoperative nausea and vomiting and against emesis caused by cancer chemotherapy, radiation therapy, and toxins. Potential side effects are similar to those of phenothiazines, your extrapyramidal reactions, sedation, and hypotension. The pharmacology behind these medications is discussed further in Chapter 24. So there is another black box warning on droperidol. Droperidol may pose a risk for fatal dysrhythmias owing to the prolongation of the QT interval. Accordingly, patients receiving the drug should undergo an EKG evaluation prior to its administration. Which takes us now to metoclopramide. The easier name is Reglan. Reglan suppresses emesis through a blockade of dopamine receptors in the CTZ. The drug can suppress postoperative nausea and vomiting, as well as emesis caused by anti-cancer drugs, opioids, toxins, and radiation therapy. The pharmacology of Reglan is discussed later under prokinetic agents. So we'll get back to that one. Cannabinoids. Two cannabinoids, dronabinol, marinol, and nabilone, Succinate, are approved for medical use in the United States. Both drugs are related to marijuana. Dronabinol is a principal psychoactive agent in C. sativa. Nabilone is a synthetic derivative of dronabinol. A third cannabinoid preparation sold as Sativex is available in Canada for treating of neuropathic pain, but is not yet FDA approved in the United States when this book was released. The basic pharmacology of all THC and other cannabinoids is discussed in Chapter 33. However, there are therapeutic uses. Both dronabinol and nabilone are approved for suppressing CINV. The mechanism underlying benefits is unknown, but most likely result from the activating cannabinoid receptors in and around the vomiting center. Because of their psychotomimetic effects and abuse potential, the cannabinoids are considered second-line drugs for CINV and hence should be reserved for patients who are unresponsive to or intolerant of preferred agents. In addition to its use in CINV, dronabinol is approved for stimulating appetite in patients with AIDS. The goal is to reduce AIDS-induced anorexia and prevent or reverse any kind of weight loss. However, there are adverse effects and drug interactions. In theory, the cannabinoids used medically can produce subjective effects identical to those caused by smoking marijuana. Potential unpleasant effects include temporal disintegration, dissociation, depersonalization, and dysphoria. Because of these effects, cannabinoids are contraindicated for patients with psychiatric disorders. In addition to their subjective effects, cannabinoids can cause tachycardia and hypotension, and therefore must be used with caution in patients with cardiovascular disease. The cannabinoids can cause drowsiness and hence should not be combined with alcohol, sedatives, and central nervous system depressants. The abuse potential. Because they mimic the subjective effects of marijuana, cannabinoids have some potential for abuse. When first approved for medical use, both drugs were classified under the Schedule II of the Controlled Substance Act, a classification reserved for drugs with a high abuse potential. However, in 1998, the manufacturers of dronabinol petitioned the Drug Enforcement Agency to reclassify the drug under Schedule III. Two arguments for the reduced classification were offered. Because of its slow onset, the medication does not produce the same high produced by smoking marijuana, and two, there is little to no interest in dronabinol on the street. Apparently, the DEA agreed. Dronabinol is now classified a Schedule III medication. Nabilone, however, remains under the Schedule II, although its abuse potential seems no greater than that of dronabinol. So, what are the preparation dosages and administration? Dronabinol is supplied in capsules, 2.5, 5, and 10 milligrams for oral use. To prevent emesis, and usual dose is 5 milligrams every 4 to 6 hours as needed. To stimulate appetite in patients with AIDS, the recommended initial dose is 2.5 milligrams before lunch and supper. If this dosage is intolerable, 2.5 milligrams once daily may be tried. For nabilone, is supplied in a 1 milligram capsule for oral use. The usual dosage is either 1 to 2 milligrams twice daily. So that brings us now to CINV, or chemotherapy-induced nausea and vomiting. Many anti-cancer drugs cause severe nausea and vomiting, leading to dehydration, electrolyte imbalances, nutrient depletion, and esophageal tears. Worse yet, these reactions can be so intense that patients may discontinue chemotherapy rather than endure further discomfort. Fortunately, CINV can be minimized with the antiemetics. Chemotherapy is associated with three types of emesis: anticipatory, acute, and delayed. Anticipatory emesis occurs before anti-cancer drugs are actually given. It is triggered by the memory of severe nausea and vomiting from previous rounds of chemotherapy. Acute emesis begins within minutes to a few hours after receiving chemotherapy and often resolves within 24 hours. In contrast, delayed emesis develops a day or more after the drug is administered. For example, with cisplatin, emesis is maximum 48 to 72 hours after dosing and can persist for up to 6 to 7 days. Antiemetics are more effective at preventing CINV than at suppressing CINV that has already begun. Accordingly, antiemetics should be administered before chemotherapy. For prevention, antiemetics may be given orally or parenterally. Both routes are equally effective, although the dosages may differ. In general, oral therapy is preferred. However, if emesis is ongoing, oral therapy won't work, and hence the parenteral therapy is required. The antiemetic regimen for a particular patient is based on the emetogenic potential of the chemotherapy drug being used. The antiemetic regimen for a particular patient is based on the emetogenic potential of the chemotherapy drugs being used. For drugs with a low risk for causing emesis, a single antiemetic, such as dexamethasone, may be adequate. For drugs with a more moderate or high risk for causing emesis, a combination of antiemetics is needed. The current regimen of choice for patients taking highly emetogenic drugs consists of three agents: aprepitant plus dexamethasone plus a 5-HT3 antagonist, so Sofran or palanositron. Lorazepam may be added to reduce anxiety and anticipatory emesis and to provide amnesia. The superior efficacy of combination therapy suggests that anti-cancer drugs may induce emesis by multiple mechanisms. The following table, 64.3, shows representative regimens for preventing CINV in patients receiving anti-cancer drugs with low, moderate, and high emetogenic risk. So here is a good spot to hit pause and review the representative regimens for preventing chemotherapy-induced nausea and vomiting. Which brings us to now nausea and vomiting of pregnancy. Nausea and vomiting of pregnancy, also known as NVP, is extremely common, especially during that first trimester. About 50% of women experience nausea plus vomiting, and another 25% experience nausea alone. A few women experience hyperemesis gravidarum, a severe form of NVP characterized by dehydration, ketonuria, hypokalemia, and loss of 5% or more of their body weight. Fortunately, most cases of NVP abate early in pregnancy. About 60% resolve within 13 weeks, and 90% resolve by the end of their 20 weeks. Although NVP is commonly called morning sickness, it can occur any time of the day. NVP can be managed with drugs and with non-drug measures. Non-drug measures include eating small portions of food throughout the day, avoiding odors, foods, and supplements that could trigger NVP, such as your fatty foods, spicy foods, or iron tablets, and the use of alternative treatments, such as acupuncture and ginger. Despite use of these non-drug measures, about 10% of women still require drug therapy. So there is patient-centered care across the lifespan. Other gastrointestinal drugs for all ages. Something to take a look at here. So again, a good spot to hit that pause button. The first-line therapy consists of two drug combination, doxylamine plus a vitamin B6. In randomized controlled trials, the combination reduced NVP by 70% and showed no evidence of adverse fetal outcomes. Doxylamine and vitamin B6 are available in a fixed-dose combination sold as diclectin and diclegis. Diclegis is sold in delayed-release tablets containing 10 milligrams each of doxylamine and pyridoxine. Dosing starts with 2 tablets at bedtime. If doxylamine and vitamin B6 fail to suppress NVP, alternatives include prochlorperazine, metoclopramide, and ondansetron. The methylprednisolone may be tried as a last resort, but only after 10 weeks of gestation. Earlier use greatly increased the risk for a cleft lip, with or without a cleft palate. Which brings us to drugs for motion sickness. Motion sickness can be caused by the sea, air, automobile, and space travel. Symptoms are nausea, vomiting, pallor, and cold sweats. Drug therapy is most effective when given prophylactically rather than after symptoms begin. So, your options include scopolamine. Scopolamine is a muscarinic antagonist, is our most effective drug for prevention and the treatment of motion sickness. The benefits derive from suppressing nerve traffic in the neuronal pathway that connects the vestibular apparatus of the inner ear to the vomiting center. The most common side effects are dry mouth, blurred vision, and drowsiness. More severe but less common effects include urinary retention, constipation, and disorientation. Scopolamine is available in oral, subcutaneous, and transdermal dosing. The transdermal system, an adhesive patch that contains scopolamine, is applied behind the ear. Anticholinergic side effects with transdermal administration may be less intense than with the oral or subcutaneous dosing. Antihistamines. The antihistamines used most often for motion sickness are dimenhydramine, meclizine or Antivert, and cyclivert. Because these drugs block receptors for acetylcholine in addition to the receptor for histamine, they appear in Table 64.1 as a subclass under anticholinergics. Suppression of motion sickness appeared to result from blocking histaminergic, the histamine 1 or H1, and muscarinic cholinergic receptors in the neuronal pathway that connects the inner ear to the vomiting center. The most prominent side effect includes sedation, resulting from a blocking H1 receptor. Other side effects include dry mouth, blurred vision, urinary retention, and constipation, result from the blocking of muscarinic receptors. Antihistamines are less effective than scopolamine for treating motion sickness, and sedation further limits their utility. Which takes us now to the antidiarrheal agents. Diarrhea is characterized by stools of excessive volume and fluidity, and by increased frequency of defecation. Diarrhea is a symptom of a GI disease and not a disease per se. Causes include infection, maldigestion, inflammation, and functional disorders of the bowel. The most serious complication of diarrhea are dehydration and electrolyte depletion. Management is directed at the diagnosis and treatment of the underlying disease, replacement of lost water and salts, relief of cramping, and reducing passage of unformed stools. Antidiarrheal drugs fall into two major categories or groups: specific antidiarrheal drugs and nonspecific antidiarrheal drugs. The specific agents are drugs that are used to treat the underlying cause of diarrhea. Included in this group are anti-infective drugs and drugs used to correct malabsorption syndromes. Nonspecific antidiarrheals are agents that act on or within the bowel to provide symptomatic relief. These drugs do not influence the underlying cause, however. So, nonspecific antidiarrheal agents are things including opioids. Opioids are our most effective antidiarrheal agent. By activating the opioid receptors in the GI tract, these drugs decrease intestinal motility and thereby slow intestinal transit, which allows more time for absorption of fluid and electrolytes. In addition, the activation of the opioid receptors decreases secretion of the fluid into the small intestine and increases the absorption of fluid and salt. The net effect is to present the large intestine with less water. As a result, the fluidity and volume of stools are reduced, as is the frequency of defecation. At the doses employed to relieve diarrhea, subjective effects and dependence do not occur. However, excessive doses can elicit typical morphine-like subjective effects. If severe overdose occurs, it should be treated with an opioid antagonist, so Narcan or naloxone. In patients with inflammatory bowel disease, opioids may cause toxic megacolon. Several opioid preparations, your diphenolate, diphenoxin, loperamide, paregoric, and opium tincture, are approved for diarrhea. Of these, diphenolate or Lamodal and loperamide, Imodium, are the most frequently employed. Pharmacologic properties of these agents are discussed later. Dosages for diarrhea are shown here in this following table. So again, here's a good spot to hit pause so that you can take a look at the opioids used to treat diarrhea. Diphenolate. Diphenolate is an opioid used only for diarrhea. The drug is insoluble in water and hence cannot be abused by parenteral routes. When taken orally, in antidiarrheal doses, diphenolate has no significant effect on the CNS. However, if taken in high doses, the drug can elicit typical morphine-like subjective effects. Diphenolate is formulated in combination with atropine. The combination, best known as Lamodal, is available in tablets and oral liquid. Each tablet or oral 5 milliliters of liquid contain 2.5 milligrams of diphenolate and 0.025 milligrams of atropine sulfate. The atropine is present to discourage diphenolate abuse. Doses of the combination that are sufficiently high to produce euphoria from the diphenolate would produce unpleasant side effects from the correspondingly high dose of atropine. Accordingly, the combination has a very low potential for abuse and is classified under a Schedule 5 of the CSA. Loperamide, also known as Imodium, is a structural analog of meperidine. The drug is employed to treat diarrhea and to reduce the volume of discharge from ileostomies. Benefits derive from suppressing bowel motility and from suppressing fluid secretion into the intestinal lumen. The drug is poorly absorbed and does not readily cross the blood-brain barrier. Very large oral doses do not elicit morphine-like subjective effects. Imodium has little or no potential for abuse and is not regulated under the CSA. The drug is supplied in 2 milligram capsules, in 2 milligram tablets, and in liquid formula, 1 milligram per 5 ml, and in 1 milligram per 7.5 ml. Diphenolate. Diphenolate is the major active metabolite of diphenolate. like diphenoxylate and diphenoxin, can elicit morphine-like subjective effects at high doses. To discourage excessive dosing, diphenoxin, like diphenoxylate, is formulated in combination with atropine. The combination is marketed as Motofen because its abuse potential is somewhat greater than that of diphenoxylate plus atropine. Motofen is classified as a Schedule IV product. Paregoric. Paregoric is a dilute solution of opium containing morphine 0.4 mg per ml as its main active ingredient. The primary use is diarrhea, although paregoric has the same approved use as morphine. Antidiarrheal doses cause neither euphoria nor analgesia. Very high doses can cause typical morphine-like responses. Paregoric has a moderate potential for abuse and is classified under the Schedule III of the CSA. And that brings us to the opium tincture. Opium tincture is an alcohol-based solution that contains 10% opium by weight. The principal active ingredient, morphine, is present at 10 mg per ml. The primary indication is diarrhea. In addition, an opium tincture may be given to suppress symptoms of withdrawal in opioid-dependent neonates. When administered in antidiarrheal doses, opium tincture does not produce analgesia nor euphoria. However, high doses can cause typical opioid agonist effects. Opium tincture has a high potential for abuse and is classified as a Schedule II agent. That brings us to the other non-specific antidiarrheal, the first being bismuth subsalicate. Bismuth, or Pepto-Bismol, is effective for the prevention and treatment of mild diarrhea. For prevention, the dosage is 262 mg tablets 4 times a day for up to 3 weeks. For treatment, the dosage is 2 tablets every 30 minutes for up to 8 doses. Users should be aware that the drug may blacken stools and the tongue. Bulk-forming agents. Paradoxically, methylcellulose, polycarbophil, and other bulk-forming laxatives can help manage diarrhea. Benefits derive from making stools more firm and less watery. Stool volume is not decreased. The bulk-forming laxatives are discussed in Chapter 63. Anticholinergic antispasmodics. Muscarinic antagonists, so atropine, can relieve cramping associated with diarrhea, but do not alter fecal consistency nor their volume. However, owing to the undesirable side effects, like the blurred vision, photophobia, dry mouth, urinary retention, and tachycardia, anticholinergic drugs are of limited use. The pharmacology of the muscarinic blockers are discussed more in Chapter 12. The management of infectious diarrhea. So, general considerations. Infectious diarrhea may be produced by an enteric infection with a variety of bacteria or protozoa. These infections are usually self-limited. Mild diarrhea can be managed with nonspecific antidiarrheals. In many cases, no treatment is required at all. Antibiotics should be administered only when clearly indicated. Indiscriminate use of antibiotics is undesirable in that it 1. Can promote emergence of antibiotic resistance, and 2. Can produce an asymptomatic carrier state by killing most of the infectious agents. Conditions that do merit antibiotic treatment include severe infection with Salmonella, Shigella, Campylobacter, or Clostridium species. Traveler's diarrhea. Tourists are often plagued with infectious diarrhea. In most cases, the causative organism is E. coli. As a rule, treatment is unnecessary. Infection with E. coli is self-limited and will run its course in a few days. However, if symptoms are especially severe, treatment with monofluoroquinolone antibiotics or ciprofloxacin or norfloxacin is indicated. Azithromycin is preferred for children and for pregnant women. Rivaroxaban or xifaxan may also be used, provided that the patient is not pregnant or febrile and that stools are not bloody. For patients with mild symptoms, relief can be achieved with loperamide, a non-specific antidiarrheal. However, by slowing peristalsis, loperamide may delay export of the offending organism and may thereby prolong the infection. Several measures can reduce acquisition of traveler's diarrhea. Two measures: avoid local drinking water and carefully washing foods, and highly are considered highly effective. Certain drugs, ciprofloxacin and norfloxacin, can be taken for prophylaxis. However, because these drugs can cause serious side effects, prophylaxis is not generally recommended. Lastly, travelers can be vaccinated against some pathogens. Oral vaccinations with Dukoral protects against diarrhea caused by E. coli and Vibrio cholera. Which brings us to C. diff, associated diarrheas. Clostridium difficile is a gram-positive anaerobic bacillus that infects the bowel. Injury results from a release of bacterial toxins. Symptoms range from relatively mild to severe. Abdominal discomfort, nausea, fever, diarrhea, toxic megacolon, pseudomembranous colitis, colon perforation, sepsis, and even death. C. diff infection and its treatment is discussed further in Chapter 70. So, drugs for the irritable bowel syndrome. Irritable bowel syndrome, or IBS, is the most common disorder of the GI tract, affecting an estimated 20% of Americans, about 54 million people. The incidence is 3 times higher in women than it is in men. IBS is responsible for 12% of all visits to the primary care physician and 28% of all visits to the gastroenterologist. The direct medical cost is estimated at $8 billion a year, and the indirect costs are even higher, about $25 billion. IBS is the second only to the most common cold and is the leading cause of days missed from work. IBS is a GI disorder characterized by crampy abdominal pain, sometimes severe, occurring in association with diarrhea, constipation, or both. Formally, IBS is defined by the presence, for at least 12 weeks in the past year, of abdominal pain or discomfort that cannot be explained by structural or chemical abnormalities, and that has at least two of the following features. One being pain is relieved by defecation. The onset was associated with change in frequency of stool. Onset of pain occurred in association with a change in stool consistency. IBS has four major forms, and they are characterized as follows: abdominal pain in association with diarrhea, abdominal pain in association with constipation, abdominal pain in association with alternating episodes of diarrhea and constipation, and the last one, abdominal pain in association with alternating episodes of diarrhea and constipation less than 25% of the time. No one knows what really causes IBS. Despite extensive research, there's no underlying pathophysiologic mechanism that has been identified. What we do know is that the bowel appears hypersensitive and hyperresponsive. As a result, mild stimuli that would have no effect on most people can trigger an intense response. In addition, we know that symptoms can be triggered by stress, depression, and dietary factors that include caffeine, alcohol, fried foods, high-fat foods, gas-generating vegetables, and too much sorbitol, a sweetener found in chewing gum and some diet products. Overproduction of the gastric acid and the excessive bacterial colonization of the small intestine have also been implicated. Fortunately, many people achieve significant relief with treatment. Non-drug measures and drug therapy are employed. Patients should keep a log to identify foods and stressors that trigger symptoms. Because large meals stretch and stimulate the bowel, switching to smaller, more frequent meals may help. Increasing dietary fluid and fiber may reduce constipation. Two groups of drugs are used for treatment: non-specific drugs and drugs specific for IBS. Both groups are going to get discussed here next. The first being the non-specific drugs. There's four groups of drugs: antispasmodics, bulk-forming agents, antidiarrheals, and tricyclic antidepressants. All have been employed for years to provide symptomatic relief. However, a report from the American College of Gastroenterology concluded that for most of these agents, there is no good proof of clinical benefit. Specifically, after reviewing available data, the authors conclude that loperamide and the bulk-forming agents are no better than a placebo at relieving global symptoms of IBS. In contrast, they concluded that there is good evidence that TCAs can reduce abdominal pain and that this benefit is unrelated to relief of depression. Regarding antispasmodics, they concluded that the available data is insufficient to make a recommendation for or against its use. Studies suggest that for some patients, symptoms can be relieved with antibiotics or an acid suppressant. An example, in one study, researchers observed that many patients with IBS have excessive bacteria in the small intestine. When these people were treated with antibiotics, bacterial colonization was reduced, and so were symptoms of IBS. In a more recent study, treatment of oral rifaximin reduced symptoms in some patients with IBS. Another study evaluated the effects of drugs that suppress production of stomach acid in patients who routinely experienced exacerbations of symptoms after eating. Two kinds of acid suppressants were used, a proton pump inhibitor and a histamine 2 receptor blocker. In all cases, patients experienced a significant reduction of postprandial urgency and other symptoms. Benefits developed quickly and reversed when the drugs were stopped. So, inflammatory bowel syndrome, specific drugs. In this section, we discuss three drugs approved for IBS. These are allocetrone and alloxodolone and lubiprostone. Although a fourth drug, tegaserod, exists, it is only used in emergency situations owing to its risk for serious cardiovascular events. So, we'll start with the first one. Allocetrone. Allocetrone is a potentially hazardous drug approved for IBS in women. Allocetrone was first approved in February 2000, and then in response to reports of severe GI toxicity and several deaths, approval was withdrawn about 9 months later. Less than 10 months after being introduced, however, in 2002, allocetrone was reapproved by the FDA, marking the first time the agency has allowed a drug back onto the market after having been pulled for safety reasons. To reduce risk, prescribers, patients, and pharmacists must adhere to a strict risk management program. So its indication. Allocetrone is approved only for treating women with severe IBS that has lasted for 6 months or more and has not responded to conventional treatment. IBS-D is considered severe if the patient experiences one or more of the following: frequent and severe abdominal pain or discomfort, frequent bowel urgency or fecal incontinence, disability or restriction of daily activities because of IBS, and less than 5% of IBS cases qualify as severe. Its mechanism of action. So how does it truly work? Well, it causes selective blockade of the 5-HT3 receptors, which are found primarily in the neurons that innervate the viscera. In patients with IBS-D, allocetrone can decrease abdominal pain, increase colonic transit time, reduce intestinal secretions, and increase absorption of water and sodium. As a result, the drug can increase stool firmness and decrease both fecal urgency and frequency. Presumably, all of these effects result from a 5-HT3 blockade. Symptoms decline in 1 to 4 weeks after starting the drug and resume 1 week after stopping the drug. Pharmacokinetics. The administration is oral and the absorption is rapid but incomplete, only about 50 to 60%. Bioavailability is decreased by food. Plasma levels peak about 1 hour after dosing. Allocetrone undergoes extensive metabolism by hepatic cytochrome P450 enzymes, followed by the excretion primarily in the urine. The half-life is 1.5 hours. So, drug interactions. Allocetrone does not interact with theophylline, oral contraceptives, cisapride, ibuprofen, alprazolam, amitriptyline, fluoxetine, or hydrocodone combined with acetaminophen. Because elazotran is metabolized by cytochrome P450 enzymes, drugs that interfere with these enzymes may alter elazotran levels, leading us to adverse effects and contraindications. Although elazotran is generally well tolerated, it can cause severe adverse effects. Deaths have occurred. The most common problem, however, is constipation, which can be complicated by impaction, bowel obstruction, and even perforation. Which brings us to its black box warning. Elazotran can cause ischemic colitis. Ischemic colitis and complications of constipation have led to hospitalizations, blood transfusions, surgery, and death. Owing to its potential for GI toxicity, elazotran is contraindicated for patients with ongoing constipation or a history of any of the following: chronic constipation, severe constipation, or sequelae from constipation, intestinal obstruction or stricture, toxic megacolon, or GI perforation or adhesions, ischemic colitis, impaired intestinal circulation, thrombophlebitis, or hypercoagulable states, Crohn's disease or ulcerative colitis, and diverticulitis. So, the risk management program, therefore, to ensure the best possible benefit to risk ratio, the manufacturers and the FDA have established a risk management program that involves active participation of the patient, the prescriber, and the pharmacist. The details can be found at the following website. So here's a good spot to pause if you want to look up that website. It's called Lotron XPPL. Its preparation, dosage, and administration. Elozatran is applied in a 0.5 and 1 milligram tablet. The recommended initial dose is currently half a tablet twice daily. If after 4 weeks the dosage is well tolerated but inadequate, it can be increased to 1 milligram twice a day. If after 4 weeks at the higher dosage treatment is still inadequate, the drug is not likely to help and should be stopped. Patients who develop constipation or signs of ischemic colitis, so rectal bleeding, bloody diarrhea, or new or worsening abdominal pain, should immediately inform their prescriber and discontinue the drug. Those with ischemic colitis should never use elazotran again. Those with constipation may resume treatment, but only after the constipation has resolved and only on the advice of the prescriber. If constipation does not resolve, the prescriber should be seen for evaluation. Which brings us to the next medication, Eluxidoline, or Viberzi. Viberzi is approved for IBS-D in both men and women. Viberzi is a mu and kappa opioid receptor agonist. By triggering these receptors, motility in the bowel is slowed. The dosage is 100 milligrams twice daily, taken with food. A decreased dose of 75 milligrams twice daily is recommended for patients without a gallbladder, those who are unable to tolerate the higher dose, and those who have mild or moderate hepatic impairment. The most common adverse reactions include constipation, nausea, and abdominal pain. That brings us to the next medicine, lubiprostone, or Amitiza. Amitiza is approved for IBS-C in women 18 and older. Unfortunately, benefits are modest. The drug can reduce abdominal pain and discomfort, but only in small percentages of patients. The efficacy against IBS in men has not been established. In addition to its use in IBS-C, Amitiza is used for chronic idiopathic constipation in women and men. As discussed in Chapter 63, Amitiza causes selective activation of the chloride channel and epithelial cells of the intestine and thereby promotes secretion of chloride-rich fluid into the intestinal lumen and enhances motility of the small intestine of the colon. The dosage for IBS-C is lower than that for CIC, 8 micrograms twice daily versus 24 micrograms twice daily. As a result, compared with patients treated for CIC, patients treated for IBS-C experience less nausea, diarrhea, and chest discomfort. To reduce the incidence of nausea, all doses should be taken with food and water. Which brings us now to drugs for inflammatory bowel disease. Inflammatory bowel disease has two forms: Crohn's disease and ulcerative colitis. Crohn's disease is characterized by transmural inflammation and usually affects the terminal ileum, but can also affect other parts of the GI tract. Ulcerative colitis is characterized by the inflammation of the mucosa and submucosa of the colon and rectum. Both diseases produce abdominal cramps and diarrhea. Ulcerative colitis may cause rectal bleeding as well. About 15% of patients with ulcerative colitis eventually have an attack severe enough to require hospitalization for IV glucocorticoid therapy, which produces remission in 60% of patients. The remaining 40% usually require a total colectomy. In the US, IBD afflicts about 1.4 million people. There is general agreement that IBD results from an exaggerated immune response directed against normal bowel flora, but only in genetically predisposed people. Drug therapy of IBD is shown in Table 64.5. Five types of drugs are employed: the 5-aminosalicylates, glucocorticoids, immunosuppressants, immunomodulators, and antibiotics. None of these drugs is curative. At best, drugs may control the disease process. Patients frequently require therapy with more than one agent. So here is a good spot to hit pause so you can look at the therapeutic options for inflammatory bowel disease. So we'll start off with the first one, the 5-aminosalicylates. The 5-aminosalicylates are used to treat mild or moderate ulcerative colitis and Crohn's disease, and to maintain remission after symptoms have subsided. 4-aminosalicylates are available: sulfasalazine, mesalamine, osalazine, and basalazide. Starting off with the first, sulfasalazine. Sulfasalazine, also known as asulfidine, belongs to the same chemical family as the sulfonamide antibiotics. However, although similar to the sulfonamides, sulfasalazine is not employed to treat infections. Its only approved indications are IBD and rheumatoid arthritis. So we'll discuss that more in chapter 57. Its actions. Sulfasalazine is metabolized by the intestinal bacteria into two compounds, the 5-aminosalicylic acid and sulfapyridine. The 5-ASA is the component responsible for reducing inflammation. Sulfapyridine is responsible for adverse effects. Possible mechanisms by which the 5-ASA reduces inflammation include the suppression of prostaglandin synthesis and suppression of the migration of inflammatory cells into the affected regions. So, its therapeutic use. Sulfasalazine is most effective against acute episodes of mild to moderate ulcerative colitis. Responses are less satisfactory when symptoms are severe. The medication can also benefit patients who suffer from Crohn's disease. However, they also come with adverse effects, which include nausea, fever, rash, and arthralgia, which are most common. Hematologic disorders such as agranulocytosis, hemolytic anemia, and macrocytic anemia can also occur. Accordingly, complete blood counts should be obtained periodically. Sulfasalines appear safe during pregnancy and lactation. So, its preparation, dosage, and administration. Sulfasalazine is available in 500 mg immediate and delayed release oral tablets. The initial adult dosage is 500 mg per day. The maintenance dosage ranges from 2 to 4 grams per day, given in divided doses. Which brings us to the next medication, mesalamine. Mesalamine is a generic name for a 5-ASA, the active component in sulfasalazine. The drug is used for acute treatment of mild to moderate IBD and for maintenance therapy of IBD. Mesalamine has been administered for retentional enema by rectal suppository or by mouth. adverse effects are milder than with sulfasalazine. The most common effects of oral therapy are headache and a GI upset. The adult oral dosage is 800 milligrams 3 times a day, or 1 gram 4 times a day, or 1.5 gram once a day, or 2.4 to 4.8 grams once a day, depending on the different variations of the tablet. A 1000 milligram rectal suppository can also be administered once a day at bedtime. The retention enema is administered once daily. Osalazine. Osalazine is a dimer composed of two molecules of 5-ASA, the active component once again of sulfasalazine. Also, osalazine is approved for the maintenance therapy of ulcerative colitis in patients who can't tolerate sulfasalazine. The most common adverse effects are watery diarrhea, which occurs in 17% of the patients. Other adverse effects include abdominal cramps, pain, acne, rash, and joint pain. Osalazine is supplied in a 250 milligram capsule, and the adult dosage is 500 milligrams twice a day with food. Bringing us to the last one, the balsalicide, or colazole, which is an aminosalicylate indicated for mildly to moderately active ulcerative colitis. As with sulfasalazine, colonic bacteria act on the balsalicide to release the 5-ASA, the active portion of the molecule. Nearly all of the drug remains in the intestine, less than 1% is absorbed. As a result, balsalicide is well tolerated. The most common adverse effect is a headache, abdominal pain, diarrhea, and nausea. The medication is available in 750 milligrams oral capsule, and the recommended dosage is 3 capsules 3 times a day for 8 to 12 weeks. This dosage delivers 2.4 grams of free 5-ASA to the colon daily. Leading us to glucocorticoids. The basic pharmacology of glucocorticoids is discussed in chapter 56. So the discussion here is limited to their use in IBD. Glucocorticoids can relieve symptoms of ulcerative colitis and Crohn's disease. Benefits derive from the anti-inflammatory action. Prolonged use of glucocorticoids can cause severe adverse effects, including adrenal suppression, osteoporosis, increased susceptibility to infection, and Cushingoid syndrome. Glucocorticoids are indicated primarily for the induction of remission, not for long-term maintenance. The administration is either IV or PO. Oral budesonide or Entocort is approved for mild to moderate Crohn's disease that involve the ileum and ascending colon. Entocort extended release capsules are formulated to release budesonide when it reaches the ileum and ascending colon. As a result, high local concentrations are produced. Systemic effects are lower than with other glucocorticoids because absorbed budesonide undergoes extensive first-pass metabolism. Immunosuppressants. Immunosuppressants are used for long-term therapy of selected patients with ulcerative colitis and Crohn's disease. Clinical experience is greatest with azathioprine and mercaptopurine. So, we'll talk about both of those medications. These drugs are discussed together because one is the active form of the other. Mercaptopurine is the active drug, whereas azathioprine is a prodrug that undergoes conversion in the body. Although not approved for IBD, azathioprine or Imuran and mercaptopurine have been employed with success to induce and maintain remission in both ulcerative colitis and Crohn's disease. Because onset of effects may be delayed for up to 6 months, these agents cannot be used for acute monotherapy. Furthermore, because these drugs are potentially more toxic than aminosalicylates or glucocorticoids, they are generally reserved for patients who have not responded to the traditional therapy. Major adverse effects are pancreatitis and neutropenia. At the doses used for IBD, these drugs are neither carcinogenic nor teratogenic. Cyclosporins. Cyclosporin is a stronger immunosuppressant and acts fast. When used for IBD, the drug is generally reserved for patients with acute, severe ulcerative colitis or Crohn's disease that has not responded to glucocorticoids. For these patients, continuous IV infusions can rapidly induce remission. In addition to IV administration, the drug has been administered orally in low doses to maintain remission, but results have been inconsistent. Cyclosporin is a potentially toxic compound that can cause renal impairment, neurotoxicity, and generalized suppression of the immune system. Methotrexate. In patients with Crohn's disease, methotrexate can promote short-term remission and thereby reduce the need for glucocorticoids. Because the doses employed are low, about 25 milligrams once a week, the toxicity associated with a high-dose therapy in cancer patients should be avoided. Immunomodulators. The drugs discussed in this section are monoclonal antibody products that modulate immune responses. There's three of these drugs: infliximab, certolizumab, and adalimumab, which are inhibitors of tumor necrosis factor alpha. The fourth drug, natalizumab, interferes with the alpha integrin. These drugs are generally considered second-line agents. However, some authorities now recommend their use early in treatment with the hope of inducing remission quickly and maintaining in remission longer. So we'll start off with the first, infliximab or Remicade, which is a monoclonal antibody designed to neutralize the tumor necrosis factor alpha, a key immunoinflammatory modulator. The drug is indicated for moderate to severe Crohn's disease and ulcerative colitis. In clinical trials, Remicade reduced symptoms in 65% of patients with moderate to severe Crohn's disease and produced clinical remission in 33%. Good responses are also seen in ulcerative colitis. As discussed in Chapter 57, Remicade is also used for rheumatoid arthritis. During clinical trials, 5% of patients dropped out because of serious adverse effects. Infections and infusion reactions were the most common. Tuberculosis and opportunistic infections are the particular concern. Infusion reactions include fever, chills, pruritus, urticaria, and cardiopulmonary reactions, so chest pain, hypotension, hypertension, and dyspnea. Infliximab may also increase the risk for lymphoma, especially among patients with highly active disease or those on long-term immunosuppressive therapy. For patients with Crohn's disease or ulcerative colitis, treatment consists of an induction regimen, so 5 milligrams per kilogram infused at 0, 2, and 6 weeks, followed by the maintenance infusion of 5 milligrams per kilogram every 8 weeks thereafter. A basic pharmacology of the medicine is discussed in further detail in Chapter 57, which leads us now to antibiotics. Antibiotics, such as Flagyl and ciprofloxacin, can help control symptoms in patients with mild to moderate Crohn's disease. In contrast, antibiotics are largely ineffective against ulcerative colitis. So, we'll start with Flagyl. In patients with mild to moderate Crohn's disease, Flagyl is effective as sulfasalazine. The dosages employed are 750 milligrams 3 times a day and are considered high. Furthermore, because relapse is likely if Flagyl is discontinued, long-term therapy is required. Unfortunately, prolonged use of high-dose Flagyl poses a risk for peripheral neuropathy. Although Flagyl can help patients with Crohn's disease, the benefits are minimal in those with ulcerative colitis. The pharmacology of Flagyl is discussed further in Chapter 76, which leads us now to the ciprofloxacin, or Cipro. Like Flagyl, Cipro is highly effective in patients with mild to moderate Crohn's disease. Typical dose is 500 milligrams twice daily. In one study, Cipro produced a complete or partial remission in 72% of those treated. Combining Cipro with infliximab is superior to either drug used alone. Like Flagyl, Cipro is of little benefit in ulcerative colitis, and the pharmacology of Cipro is also presented in Chapter 76. Prokinetic agents. Prokinetic agents, or drugs, increase the tone and motility of the GI tract. Indications include gastroesophageal reflux disease, CINV, and diabetic gastroparesis. So, we'll talk about a couple medications here. We'll start again with Reglan, or metoclopramide, which has two beneficial actions. It suppresses emesis and increases upper GI motility. So its therapeutic use. The indication depends on the route. Oral has two approved uses: a diabetic gastroparesis and suppression of gastroesophageal reflux. In the IV route, Reglan has four approved uses: suppression of postoperative nausea and vomiting, suppression of CINV, the facilitation of small bowel intubation, and the facilitation of radiologic examination of the GI tract. Off-label uses include for hiccups and for nausea and vomiting in early pregnancy. However, all good things come with some adverse effects. With high-dose therapy, sedation and diarrhea are common. Long-term high-dose therapy can cause irreversible tardive dyskinesia, characterized by repetitive involuntary movements of the arms, legs, and facial muscles. Older adults are especially vulnerable. To reduce the risk of tardive dyskinesia, treatment should be as brief as possible, using the lowest effective dose. Owing to its ability to increase gastric and intestinal motility, Reglan is contraindicated in patients with GI obstruction, perforation, or hemorrhage. Of note, exposure to Reglan during the first trimester of pregnancy is not associated with an excess risk for congenital malformations. So its preparation, dosage, and administration. Reglan is available in four formulas. Standard tablets, 5-10 milligrams, sold as Reglan. Originally disintegrating tablets, so 5 and 10 milligrams, but sold under the name of Metozolf. And an oral syrup, sold generically, and a solution for injection, again, sold as Reglan. So dosaging will follow depending on how you're treating it. For diabetic gastroparesis, the adult dose is 10 milligrams for 30 minutes before each meal and at bedtime for 2 to 8 weeks for up to 12 weeks. For symptomatic gastroesophageal reflux, the usual dose is 10 to 15 milligrams orally 30 minutes before each meal and at bedtime for again a maximum of 12 weeks. If the symptoms are sporadic, a single dose can be taken as needed, which can be up to 20 milligrams orally 30 minutes before the precipitating situation. Which brings us now to pancreatic enzymes. The pancreas produces three types of digestive enzymes: your lipases, your amylases, and your proteases. These enzymes are secreted into the duodenum, where they can help digest fats, carbohydrates, and proteins. To protect the enzymes from the stomach acid and pepsin, the pancreas secretes bicarbonate. The bicarbonate neutralizes acid in the duodenum, and the resulting elevation in pH inactivates pepsin. Deficiencies of pancreatic enzymes can compromise digestion, especially digestion of fats. Fatty stools are characteristic of the deficiency. When secretion of pancreatic enzymes is reduced, replacement therapy is needed. Causes of deficiency include cystic fibrosis, pancreatectomy, pancreatitis, and the obstruction of a pancreatic duct. Pancreatic enzymes for clinical use are available in pancreolipase, a mixture of lipases, amylases, and proteases, prepared from hog pancreas. Trade names are Creon, Pancrease, Pertize, Ultrase, Viocase, and Senpep. All drugs, with the exception of Viocase, are supplied in delayed-release capsules designed to dissolve in the duodenum and upper jejunum. Viocase is supplied in tablets. The capsules should not be crushed, chewed, or retained in the mouth, owing to the risk for irritating the oral mucosa. Pancreolipase is generally well tolerated. The most common adverse effects are abdominal discomfort, gas, headache, and cough. Large doses can cause diarrhea, nausea, and cramping. The most serious concern is fibrosing colonopathy, seen rarely during high-dose therapy in patients with cystic fibrosis. Porcine pancreolipase contains high levels of purines and hence may pose a risk to patients with gout or hyperuricemia. Allergic reaction occurs occasionally. Acid suppressants, your histamine 2 receptor blockers or proton pump inhibitors, may be employed as adjuvants to pancreatic enzyme therapy. The objective is to raise gastric pH, protecting the enzymes from inactivation. However, acid suppressants are beneficial only when acid secretion is excessive. So, dosage is adjusted on an individual basis. Determining factors include the extent of enzyme deficiency, dietary fat content, and enzyme activity of the preparation selected. The efficacy of therapy can be evaluated by measuring the reduction in the 24-hour fat excretion. Pancreatic enzymes should be taken with every meal and snack. Which brings us now to the anorectal preparation, the nitroglycerin for anal fissures. Rectogesic is a 0.4% nitroglycerin ointment used for the relief of moderate to severe pain caused by chronic anal fissures. So, small tears in the skin that lines the anus. These fissures afflict about 700,000 Americans every year, often causing unrelenting and debilitating pain. Topical nitroglycerin relieves that pain and promotes healing by relaxing the internal anal sphincter. Nitroglycerin ointment has been used in other countries for years and is considered by many experts to be the first-line therapy. The principal adverse effect is headaches. Other anorectal preparations include various preparations that can help relieve discomfort from hemorrhoids and other anorectal disorders. Local anesthetics, your benzocaine, diabocaine, and hydrocortisone or glucocorticoid are common ingredients. Hydrocortisone suppresses inflammation, itching, and swelling. Local anesthetics reduce itching and pain. Anorectal preparations may also contain emollients, so mineral oil or lanolin, whose lubricant properties reduce irritation, and astringents, your bismuth, subgalate, witch hazel, and zinc oxide, all of which reduce irritation and inflammation. Anorectal preparations are available in multiple formulations: suppositories, creams, ointments, lotions, foams, tissues, and pads. Trade names include Preparation H, Rectogene, and Anusol. And that, I believe, concludes this chapter for today. Thank you all for listening, and I'll see you all at the next chapter. Till then, thank you, and have a good day.